So today we have Karen in our aesthetic clinic, and Karen has been to our center for a few years, and she knows that I love her genetics. Her genetics is amazing. So when you can't buy good genetics, so she's now 48, and we all sink, sag, and wrinkle on the planet Earth, and she's not a sagger. This is absolutely beautiful. Her jaw angle is fantastic. And she's not really a wrinkler, but she has some little fine lines that we're going to focus on a little bit. Some of them are sleep lines, and some are influenced by gravity and a little maturing process and genetics as well. So, but basically, the only little wrinkle she's got is here, and a little bit on her upper lip. So, Karen, we've talked about this a bit. So, when you look in the mirror, what things are you focusing on now?
Well, I've noticed, like you mentioned, the upper lip starting to wrinkle a little bit more than it used to be. And I'm starting to get narrowing in here, which is, as you've mentioned, the peanut look. And also noticed the fine lines through here. It's starting to, show when I can see it in the mirror on the sides. If the natural light's shining there, you can see it. And the tip of my nose, I've noticed, is starting to kind of droop a little bit.
Okay.
And the brow, I'm starting to get kind of narrowing in here, getting a bit of a divot.
That's really being observant. And if she can
lifting.
see that means she's a very visual girl, because with time, especially she's got a narrower face, and it's unforgiving. So any little volume loss will start to show up slowly. It's just like a slow leak in a beach ball in sections. So this area is definitely a little bit distracting because it's hollow through here. And she's absolutely right. This little peanut look happens in runners, and it happens to people who are very fit. Are you a runner?
No. Well, I run after kids.
Though. Yeah, but you're very fit. She has hardly any body fat, and so we start losing that slowly, this temporal fossa. But her eyebrows are quite flat, and we've got photos from her from years back, and even when she was in her 30s. And her brows, she's got a very feminine face, but it's much more feminine to have a little perkier brow. And she's had some neuromodulator Botox in the past that does help a little bit. We've done a little bit of fillers, but she just needs a little perk up here. And her apex of her cheek looks fine, but the cheek is made up of several artificial zones. The submalar part of the cheek through here, and we might just measure this a little bit to just kind of show the concept here. But her lips are one of her nicest features she's had all of her life, and her bottom lip is now actually stayed pretty good. It's got some little lip lines. The Cupid's bow is flattened a bit. It's lost its contour. She's got lots of little reticulated lines in the upper lip, so sometimes the lipstick doesn't go on well. So we'll kind of help erase those with the concept we're going to use here. Now her chin is actually quite nice, very feminine. The female chin is narrower and smoother than the masculine chin, so she's got very feminine features. But it is deflated a bit, and it happens from the lateral commissure marionette zone. It's not a line, it's a marionette zone, and the pre-gel sulcus a little bit. So those all she needs is some finesse to lift this up. Karen, it's obvious that she has fantastic genetics. Her DNA data is amazing, and we've talked about that with her for a number of years. So her needs are very little. We find that faces are all about genetics. We've talked about that a bit with my patients, every patient I see pretty well, and genetics are all about biology, and biology is all about physiology, and physiology is all about physics, and physics is all about math. So faces are about math. Now, the Greeks knew this, the Romans knew this, because the famous painters and architects used a figure of 5, which is 1 to 1.618. So what we're doing more and more clinics worldwide is actually taking measurements and be able to create much better results. The one measurement that stays the same throughout life is the intercanthal distance. From 20 to 100, it stays the same. So this caliper, there's several of these that are made. This one I use daily. I never take it out of my pocket. But the measurement is between the intercanthal distance here, and that distance stays the same. So the intercanthal distance here is really important. So that measurement is 1. And that should be from the medial canthus to the peak of the brow, be where the peak of the brow is on both sides. And the same on this side. Her peak of her brow is subtle, but it is right at where it should be. And then the distance, the actual width of the brow should be 1.618 equivalent. And then the brow position for the most feminine look is the head of the brow to be lined up with the inner canthus. And in her case, the left one's fine. This one's off about 1.5 millimeters, 2 millimeters. So it just makes her bridge of her nose and this glabellary appear just a little bit wide. And in the ideal perfect face, the brow matches this width. In her case, the brow's her forehead's a little bit high. So she's got a high forehead. So I can tell you that most patients intuitively know that. So do you wear your hair up or down?
Down.
Yeah, she knows that it just looks better. You'll see people with this hair all back, and your eye just doesn't like it. So she's learned that intuitively. The length of the nose should be this distance as well. The width of the lips, this distance. The width of the chin. And the apex of the cheek, which we're going to talk more about, and she has a beautiful apex, is phi as well from the corner of the inner canthus. So those measurements are very important to balance the face, because everyone's face is not a twin of each side. Each side of the face, right and left, are siblings. They're not twins. You still want to create balance and harmony, and symmetry is what we're trying to do with her today with fillers. And she doesn't need surgery. She's not a sagger. She's just a bit of a sinker. So that's what we'll do. So measuring out the apex of the cheek is very important. The cheek is made up of compartments that are not in exact zones. They just have artificial zones. Apex is the last area that we treat, and there's a submalar part of the cheek. The submalar part of the cheek is in here, and then the nasal jugal part of the cheek is here, and the upper part of the nasal jugal groove is the tear trough. Her tear trough is fine, but she's got a little bit of her nasal jugal groove here is a little bit flat, and her apex, which we'll draw in a minute, is good, but the submalar part is a little bit sunk, and same with the pre-auricular part here. So this whole pre-auricular part of the cheek is a little bit flat. And we'll see that, and she hasn't had a facelift, but good facelifts undermine the fat in the pre-auricular area, and after about 3 to 4 years, that sinks, and you get this hollowing that patients wonder what's happened, and it's just a deflation concept there. So when we measure the apex in women, in normal adult women, we go right from the lateral orbital rim and about 1 centimeter out, and drop that vertical right down with the plane of the face, and draw a line here, and then the top of the tragus to the alar crease, and then that line where that intersects is the apex of the cheek. As we noted, just looking at her apex is fine. It's the submalar part in here that needs a little bit of attention. So the cheek is made up of compartments that are not structured. They're just visual areas that we've decided over time need to be addressed. So the main compartments are the submalar cheek, which she has some deflation of, the pre-auricular cheek, which is more obvious in those that have had facelifts a few years ago. She hasn't had a facelift, but this pre-auricular cheek is, I've drawn around here, but it's just more oblong, and it deflates because she has no body fat. So she's lost this volume, and it creates a more aged look. Patients don't often see that because it's at the side of the face. And then this nasal jugal part of the cheek is the bottom part of the teardrop. The upper part of the nasal jugal groove is the tear trough. So this is just the nasal jugal zone that happens to be part of the cheek. So in essence, there's the medial part of the submalar cheek here, and a little bit of the lateral part. The last part that I address, even though I've drawn it first, is the apex. And the apex is arrived at by this horizontal line from the top of the tragus that we use the little apex ruler with to the top of the alar crease, and a vertical line drawn 1 centimeter from the orbital rim down. And you can see with her, the apex is fantastic, so it doesn't need much in the way of attention at all. So her nasal jugal part, this is why you can see this pretty flat. I don't know if that shows up in the monitor or not, but you can see this is pretty flat in here. And then she's got a little bit of sinking, but actually very little here. I wouldn't address that too much, because this side is really sunk. Is this the side you sleep on?
No, actually, I think it's the other side. But
well, it doesn't always match the side you sleep on. So the apex, you drop this line down from about 1 centimeter up from the lateral orbital rim, and try to keep that in plane with the cheek here. And we use eyebrow pencils because they come off real easy. And then the top of the alar crease to the top of the tragus. That's good. And you just draw a line where that intersects. And it's not a point, it's a zone. So that zone should be where the apex is. But her apex is beautiful. So she just needs a little attention in the submalar part. So there's a malar mound and the submalar part of the cheek. The preauricular part of the cheek, which is more obvious on her left side, and then the nasal jugal part of the cheek, which fits into here, and then the apex. The apex we do last. So she didn't really need much in the apex, just a little tiny dot to lift everything up. And so this preauricular part of the cheek is very little. I wouldn't even have touched that, but she's got the submalar part of the cheek. It needs to be lifted just a little bit. And then the nasal jugal part of the cheek, this little isthmus doesn't need to be corrected, because it's nice and full. This is deflated. And when we do the cheek first, we've learned in the correct, and we'll address this as we actually inject this and get this to lift, is to inject and reflate, not inflate. Reflation is a concept of trying to get her cheek back the way it used to be. We start at the submalar part of her cheek and lift this up, and lift the nasal jugal part up, and a little bit on her preauricular part of the cheek, and the last thing is the apex there. And that's the last part. And all that makes the nasolabial fold almost non-existent, because in many patients, and we usually rate these nasolabial folds, 1 to 5. 5 you can drive a Jeep through. Hers about a 1. But even 2s and 3s, in lifting the cheek complex, it pretty well erases the nasolabial fold. You lift this up where it should be to get her cheek back to what it used to be. And that's why I have patients bring in photos when they're younger, is not to make them look 30, but I want to see symmetry, balance, what the cheek was like, what the eyebrows were like, what the lips were like. And that's all important. Okay. So one of her minor issues is the head of the brow. This is, to me, a serendipitous kind of concept for patients, because most of them don't realize this is an issue, but the head of the brow sinking a little bit where it meets the radix yells that she's in her 40s. And we just lift this up a little bit, and that makes a huge difference. So a little difference in anatomy here makes a big difference in appearance, both ways. It makes it appear older when she's frowned for me. She's had some neuromodulator here, Botox, so it's not as obvious, but she's got this little denting. And you can usually see it easier when we lift that up a little bit. And the eyebrow itself is actually below the orbital rim. So we're going to try to lift this whole brow up just a little bit, just subtly, because that's one of her feminine features, is to get that brow up a little bit. So we'll just up about like that, so everybody can see here, and then we'll just draw this. And this is a fairly important concept to try to get this brow up, and I'm just addressing the whole brow. And because her brow is below or almost at the orbital rim, you have to be careful with the promontory of the brow and the bone that you don't push it down and make it actually lower. So there's a little technique that I can only show as I do it there. So as we reflate that a little bit. And then her temporal fossa is limited by her temporal fusion line, which you can feel, and that's fairly prominent in Karen. And then she's got this peanut look that we talked about. And I usually mark these vessels out ahead of time, but I can see them well with the lighting here. So you try to stay away from those little vessels. So our temporal fusion line's here, and there's a little junction right here where about a centimeter below the temporal fusion line and a centimeter behind the superior orbital rim here is a little junction that we use Voluma or another G1 prime filler that we can lift this, and it lifts the tail of the brow, but it doesn't lift this part of the brow. So addressing the brow, we need to address the whole brow and trying to reflate it a bit there. Okay, and then these little lines that are permanent little lines, they're more like taking the hem down in your pants. You've got these little sleep lines that happen just with time, and these are a little distressing to those that want to look their best. I'm going to turn this way a little bit so everybody can see. And we'll try to squish these a little bit. They start out like sleep lines, but they end up being permanent little creases. And sometimes they even crisscross. And then with her chin, trying to do chin reflation, it's not just the mentalis, it's the lateral oral commissure, the marionette zone, the prejowl sulcus. All of this has to be addressed in trying to reflate the chin. So it's not just the chin, it's the whole complex here. So I'm drawing this will make more sense as we end up treating this. But hers is pretty subtle, but it'll make a nice difference here. So very little on her nasolabial fold. And the nasolabial fold is not a line, it's a ditch. And those are the areas we're going to address. Her upper lip is a little out of proportion to the bottom lip. The bottom lip is very nice and full, but the top lip is a little out of proportion. So the top lip, if you're measuring this and getting very accurate, should be at 1, right in line, just a little bit lateral to the philtral columns, and the bottom lip should be this distance. So it's actually pretty good. Usually you want to have, the lips should have a little fullness in the middle and not tapered. We see these duck lips. It scares patients. Anytime we talk about lips, usually patients' pulse goes up because they think of having duck lips or sausage lips. But she just needs a little attention on the upper lip, a little definition like reframing a painting, a mirror, a framework, and a little bit on the Cupid's bow, and a little bit of this reticulated lines on the lip. So that's what we'll address there. So the techniques we'll talk about as we address them. And we're going to reflate, not inflate, and start with this whole cheek complex and start at the bottom part, which is the submalar part. So instead of the 27 gauge needle, we're using Terumo needles, which are 29 gauge, but more like 28 lumen. Half inch, which works very, very well. We still go very slow, so you can see we start the flow. And a little prick right here. So we're touching periosteum, lift up, and that zone that's just sunk a little bit is filled antegrade, not retrograde. So I'll keep as perpendicular as I can with the cameras. So we go very slow, so you don't attract any water, and just reflate. So I'm lifting, and then as I'm injecting antegrade, that filling creates the lift. We'll try to stay away from these little venules. We'll go to the lateral part of the submalar cheek. Lift that zone. I'm exaggerating a little bit here, but lift that area that's deflated. Inject slowly, and we're just reflating, not inflating. So you've got very fine features. I'm going to the medial part of this submalar cheek and just lifting this up a little bit. Now in the finer areas, just like a fine paintbrush, we've transferred to little what I call minis. These are insulin syringes that have a 31 gauge needle, and then they have an 8 millimeter needle, but it's a very small lumen, so we can inject product very smoothly because of the rheology of it. And here, because this is very thin tissue here, and I try to enter a pore, a little prick here, there, and I'll lift that little part of the nasal jugal zone of the cheek up just a little bit, and it's just like fine painting, and just in the subcutaneous tissue, not on top periosteum, just lift gently and get rid of that little shadow. This way, with the rheology of the syringe and needle, with the viscous product, you can fine-tune areas that need a little attention. So lift a little bit, and antegrade injection, small amounts, just to reflate. And with good lights in your eye, you can stay away from the little blood vessels. We're using the Terumos, which are the 29 gauge, 28, 27 lumen, and we're just going to lift this area of the preauricular cheek that's deflated a bit. This takes a little bit of product, but I'm lifting it and injecting antegrade, which the filling creates the lift. That's the concept of lift and fill. So we're just lifting this up. We're not going to try to make this perfect, but we're going to try to improve it. And you go really, really gentle and small amounts of product. And subcutaneous tissue, lifting areas that are deflated a little bit, and antegrade, slow. And this will give a nicer contour to this whole cheek, from the submalar part of the cheek to the preauricular cheek here. Okay, and then we'll blend this in with cool ultrasound gel. So blending with cool ultrasound gel is a must because it detects areas that need attention, but it also blends and molds the product that may have been a little bit not quite in the sweet spots. And this just feels perfect. There's no lumpiness, no bumpiness at all. It looks like it's being fairly aggressive to the patient, but she'll tell you that it's not. Right, Karen?
No, didn't hurt.
It's fine. So we got that contour back, and then the last part of the cheek is always the apex. It's not the first part, it's the last part. You okay, Karen?
Mm-hmm.
So the apex needs very little attention, and because it's right on top of the periosteum, in her case it's very shallow here, I'll use these little minis. So I don't need much, just I need about 0.1 ml of product. So a little prick right here, dear. So I'm right on top periosteum, push, and then lift a little bit, so that lifting is the space that's just a little bit deflated. It's just sort of giving the cheek what it needs, which we've done already, and now we're giving the cheek what it wants, is just a little bit of the apex. So you should be able to see that now lifted a little bit. Okay? So the next step is going to be her temporal fossa reflation. So temporal fossa deflation is common in men and women. And in women, you want to have a little bit of concavity to the temporal fossa zone. And in men, it's often quite flat or a little bit of convexity to it. But you certainly do not want to create convexity in women because it masculinizes them. So we're just trying to feminize her face a little bit. Okay, we'll try to stay away from these little veins. Keep your eyes shut here. We're going to go vertical. And we used to think it was on top periosteum, but it's actually right in muscle. The periosteum, the fascia is fixed to the bony tissue here. And it's limited superiorly to the temporal fusion line, so it's not going to go anywhere there. Can't go past that. So we just lift, and gently push antegrade, and the antegrade creates this lift. By pushing antegrade, the flow creates lift. So you're actually doing a reflation. And then just go down to this next little level, again vertical. I'm right on top of periosteum. It sounds a little crunchy. That's collagen. She's got nice healthy collagen. So I'm lifting, push, and you can create quite a little bubble of product. And if you're in the sweet spot right where I am now, then it'll blend. So if you go too fast, it can be a little uncomfortable. But we learned years ago with HA fillers that you go fairly slowly, and then you're not going to have a lot of water attraction, so you don't get the swelling. Anybody that's getting swelling, they're injecting too fast. The technique is not quite right. So we'll blend that in a little bit. And we'll blend this. You can blend it with ultrasound gel is the best. Just have a little bit of gel. And the part that doesn't quite lift is this sort of dimension we're going to work on in her brow. You should be able to see a little denting still above the brow. When you look straight on, if you can see her brow, then she's looking bony. You shouldn't see the bony part of the brow. That's aging process. So we want to lift this just behind the orbital rim and just below the temporal fusion line to lift this so she doesn't have this aging look. Then we'll go right on top periosteum, right here. And then we'll just lift this a little bit. And this is kind of one of the little magic spots, actually. for addressing the depressed lateral brow. And just a little bit more above it. Right on top of periosteum, she'll feel that a little bit, push, push, push. And this is one of those serendipitous things patients don't often necessarily notice, but they love the result because it just perks up that brow and takes that deflation away. So now you don't see this bony brow now. It's kind of disappeared there. And then we do the rest of the brow with reflation and contouring. That'll disappear. You don't want to make this temporal fossa too convex. You want just a little bit of concavity to it. So on the head of the brow, there are lots of little blood vessels here, little nerves. You just have to understand the anatomy where they are. And we're just going to inject right through a little pore so we stay away from the veins here. And right on top periosteum. Lift the syringe and the needle and push, and you're doing antegrade. And this is very magical. You should be able to see that on camera. Just lift right up. So that's a very little magical spot there. Right at the head of the brow, right on top periosteum. Just lift. Stay on top periosteum so you stay away from any vessels. And you just want to lift that a little bit so that it gets the contour. So you should be able to see the difference in the two brows now. Okay, now the last part of this four-dimensional approach to restoring the brows, the head of the brow, the temporal fossa base, and the actual brow itself, is the little bit of the A-frame. Her A-frame isn't too much, but it's a hollowing in the orbit and just underneath the brow, and we're just going to lift that up a little bit. So same type of cannula technique. So we bend that cannula just a little bit so it flows well. And then we enter this little hole. And you can see it just flows right over where we want it. And we'll just lift this up a little bit. So now we have the look that we want. So with a little bit of neuromodulator is part of it, and then the filler's done correctly, then you get that brow structure back. And then we're holding the bridge of the nose. We just lift this a little tiny bit. Okay, and then you blend this into place, and it's blendable because it's right on top periosteum. And then that looks unfinished because I haven't done the head of the brow on her left side. So we lift that up, and then it starts to take place. When you take this ink off, it'll make a big difference. Now, while we're on the nose here, with time and genetics, gravity, and all those things that happen to us on the planet Earth, the columella retracts. So as it retracts, if you look at photos when she's younger, her nose would be about like this. It's 95 to 105 degrees. So now it's more like 80 degrees. So we want to lift this nose up. And she's been quite aware that her nose tip is tipping down. So that's influenced by animation. Just open your eyes and just say January, February, March.
January, February, March.
Nice little smile. Okay, and then say it's cold out.
It's cold.
And see, as she talks and animates, her nose tips down. So you do a little tiny bit of neuromodulator with the depressor septi here as well, and it relaxes that pulling. And we use just 2 units here. A little prick here, dear. Okay. Then there's going to be, then we're going to lift this whole little, this is where you'll have to watch. Patients notice that we see it, but sometimes it's hard to photograph. So a little prick right at the base of the columella, and the spine of the nose is going to be a little prick right here, right there. And we just eject this about 0.15, more than you think a little bit. Very, very slow. And that just lifted that nose right up. Now she's got more like a 95 to 105 degrees, where it was 80 before. Okay, so let's finish off the brow. We want to lift this area that's a little deflated to the head of the brow, and we're not reflating, we're contouring. So it's a contouring process. A little bit here. So you just kind of go with what the face tells you, but small amounts of product here. I think we'll do her temporal fossa next here. So the temporal fossa on the left side is about equal in her case to the other side. So we're just going to go below the temporal fusion line, which is right here. It's easy to feel. Sometimes you can see it. And stay away from these little veins. I'm touching periosteum. Push, push, push. Now I got the flow going. I'm lifting subtly. So I'm actually technically, biologically, and anatomically in muscle, which is just fine. And we're going to go super slow. Go too fast, then you can create a little syncope here. But I try my best to stay away from these little veins. So, right on top, if you feel you're touching periosteum, but you're actually in a muscle. And then, if you got the sweet spot, and all filler sites have sweet spots, then you can just blend this. It'll blend where you want it to go. Okay, and a little prick right here. Lift, 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 lift. That little X is where my little magic spot is. It's going to lift the brow up. This is the magic spot right about 1 centimeter below the temporal fusion line and 1 centimeter above the orbital rim. And inject right on top periosteum. I'll get out of the way so you can see. You can see how easy it is. I can even do it with an index finger easily. Okay, and then just blend that in. So all the sweet spots, if they're there where you want them, will blend in beautifully here. So what I've done is just reflate the temporal fossa, so temporal fossa reflation. So on the eyebrow contouring, we're going to use a 27 gauge trocar and a little prick. She's had some numbing, so this shouldn't bother her too much. Okay. So we're right down under the brow bone, right on top periosteum. And taper as we go, and you can see that just creates that nice strut work here. And a little prick on this head of the brow just needs a little attention, right on top periosteum. A little more attention on this brow. Okay, there we go. Okay. And then to get a little more support, we'll just do the A-frame as well, just underneath. So you should be able to see her transformation of lifting this brow. So in the fourth dimension, it's the head of the brow, the eyebrow itself, the temporal fossa part where you can lift where it's deflated, and then just the infraorbital part here. So this is 27 gauge trocar. And a little bit more medial than where you injected the brow. And I lift this up so I can try to avoid all these little veins. A little prick here, there. So we bent that needle just a little bit again. We'll just show bending a little bit like that so I can have the angle right. Okay, and we're just right in the sweet spot here in the A-frame. Hers isn't much of an A-frame, but a little bit. But we just want to create some support just underneath the brow here. So the superior orbital part of the brow here. And you can just see immediately it gives a little lift. It's almost like a little elastic band. It goes spoing, and the brow just lifts right up. And I've also accentuated the apex of her brow that we already had measured out. We'd measured it out that it was phi, and so I wanted to lift a little bit more at the peak of her brow. Not apex, but the peak. And this we're just blending just like you do lips. is just blend these out and contour. And so with cool ultrasound gel, you can tell if you've got areas that need a little attention here. Now, if you can see her before picture and now, she's suddenly got perky brows. Do you want to have a look at your brows? Give her a mirror there so to see. She's pretty observant. Ignore this other stuff here, Karen.
Okay.
I want you to see your brows because we got your brows back.
Oh, yeah, it looks great.
Yeah, see now they're all perky.
Yeah.
You haven't had those for a while.
No.
So we just perked up her brows. Even in somebody that's got fairly flat brows, you say there's no way to lift those with neuromodulators. That's true. You have to do a little strut work and support tissue there to get those to lift. So the next step is we're going to do the left side of her cheek. So we've learned many years ago with the start of Botox in 1989 and we started using collagen in 1981, and then the energy devices, and then the Restylane, one of the HA started in Canada in 1996, Europe 1996. That we have all these devices and all these ideas, but no actual blueprint, no actual principles to go by. So what we're suggesting is you have a plan, a blueprint, like any other sort of project. You have to have a design. I do lots of blepharoplasties, and the drawing part is as important as the surgery. Surgeons that do facelift map it all out and draw it out. So we're suggesting that physicians re-look at their fillers and map it out where they're going to go and draw. So the cheeks actually have a blueprint in mind. We've already recognized that she has some submalar part of her cheek that is deflated. The apex is really quite good. Nasojugal part of the cheek is deflated, and a little bit of her preauricular cheek. So when we're trying to reflate these and contour them, we start at the base of her cheek, which is the submalar part, and we're going to lift this. So I'm actually in sub-Q. I couldn't feel the periosteum here. I'm a little too low. But that's fine. You're in sub-Q. You want to lift this. Lift the area that's deflated. And as you lift that tissue with your syringe and needle and inject antigrade, the filling creates the lift. So we need small amounts of product. We don't need a lot here. I don't really even know how much I use. My nurses do, but I just know for measurements we probably use 0.3 there. So it doesn't take much. I'm using Terumo needles, which are ½ inch. And then we'll do the preauricular part of her cheek here as well. Just a little bit here. We don't need much. And we'll try to stay away from these little vessels here. So slow, slow, slow. And lift and fill a little bit so we have this nice contour here. So there's a nice transition between the submalar cheek and her preauricular cheek. And we'll blend that all in with cool ultrasound gel. All the filler sites have sweet spots. If you get the sweet spots, then you have a magical result. Okay, on her nasojugal part of her cheek, keep your eyes shut here, we'll just try to enter a little pore, lift, and antigrade and fill, and you'll try to stay away from all these little venules. And you don't want to make this too full. It would make her nose look odd because we're on the lateral ridge of the nose almost here. But we're essentially in nasojugal groove. And then you could do the same little minis on her really shallow nasolabial fold. We'll lift it, and that space that's sunk just a little bit, we just fill it a little bit, and that filling creates the lift. So it just subtly lifts this up. Okay? And you want to just balance each side. And you can see all these areas we treated. Now they're starting to blend in nicely and mold and looking better all the time here. So now we'll address the lower part of the face. And then the blueprint of the chin, in looking at a plan, is you want to start when we start on the middle of the face, we start lower down and lift up. And the same thing with the chin zone. You want to start at the marionette zone, you'd think, because that's where your eye goes. But no, you want to start at the prejowl sulcus and get a strut work support tissue. Hers going to be a little hard to see because she's very subtle here, but she still needs some attention. So we'll lift. We're going to go right on top periosteum and I'm touching it. Lift. There's a little vein here we try to stay away from it. So lifting the area that's deflated, and that little deflated area, as we lift it, then you get that little strut work, support tissue back, and it straightens this jaw angle out. Because that straighter jaw angle is very feminine and very youthful. And then we'll lift in the marionette zone. It's not a marionette line. It's not puppet lines. They can look like lines when you get older. But we're in subacute. Lift. And to lift the lateral commissure is a little bit of a trick. So the blueprint is to lift in the sub-Q, and then the apex, open your mouth a little bit, sort of the corner, the apex of the corner, lift a little bit, and then make sure you get above the red of the lip. If you don't do that, then you don't get that nice little corner lift. So that, and we blend that in a minute here, then you'll see that lifted up there. And right in this zone, lateral to the mentalis, is a little depressed area that's deflated, so we're just reflating it. And you could use other syringes. This just is nice because it has the least chance of bruising here. Okay, we'll blend this all in at once. So on the left side, we'll mimic the right side. We'll go right at her pre-gial sulcus, which she doesn't have much, so it doesn't take much product. Right on top, periosteum, touch it. Some patients are a little sensitive. She's a Canadian girl, so she's tough. That gets that strut work support tissue back here, and then we'll try to go in a little pore, stay away from all the little veins. Notice all this work, so far she doesn't have hardly a bruise. I don't think she has any bruises. She's a bit of a leaker, but she has no bruises. Anytime you get a needle stick, that's possible. And we'll lift this up just a little bit. So we're in the marionette zone. We're lifting up a little area that's deflated and reflating it by injecting antegrade, and that lifts. So those little minis. Okay, open your mouth a little bit. So do this lateral oral commissure is sometimes the toughest thing to lift. So we always recommend patients keep their own teeth, because with the mandible getting resorbed is part of it, and gravity, genetics, time, all that influences it. Okay, and then Trumo. And the last part is we'll actually go to the mentalis. That's the last part of the blueprint. So often we do chin implants, and there's no attention to the anatomy around it. You got this little goofy plastic insert, and the rest of it looks out of place. Little prick, and we're going to go right on top periosteum, and we'll stay the angle a bit so you can see it. And just lift, push, antegrade. So this is the actual mentalis. The actual chin is the last part of chin reflation. Kind of sounds a little opposite, but that's what we do. So go really slow in. And patients that have a lot of dimpling on their chin will do tiny bits of Botox in the mentalis and the DAO as well. Sometimes you do them together. The chin and the DO doesn't like it, but small amounts of quantity there of neuromodulator. So this is the three zones I go. Mid-chin, and each side about 1.5 centimeter distance between. And then you must blend this with ultrasound gel. It does several things. The main one is it detects areas that need attention. So this always looks like I'm being aggressive, but it's just generally that pad of your fingers and palm, and you blend and rock this so there's no bumpiness at all. It's just like sculpting. And she'll tell you that I'm not being aggressive, right?
No.
It just feels good. Oh, open your mouth a little bit. So I'm just blending this. Patients feel this lateral commissure, little tiny bumps, but that just all blends in, so that'll disappear. So I'm just taking all this ink off. It's actually not ink. It looks like ink, but it's just pencil. So that's all off. If we all look at lips and look at beautiful women that have nice lips over the last 50 years will all recognize they're fuller in the bottom and a little pouty, and they're not full like all across the bottom like we see injected like trout lips and sausages. So to reestablish her lip, her bottom lip is actually very nice. But generally, most patients, most women's bottom lip is a little fuller than the top, which hers is, at a ratio of 1 to 1.618. And in her upper lip, she's recognized it's just gradually lost its shape, it's lost the contour. She's got little lip lines, and she's lost the definition. And the Cupid's bow, looking at her previous pictures when she's in her 30s, is almost gone. Just to refresh everyone's anatomy, the vermilion is the name for the zone where the lipstick goes, spelled with one L. And the vermilion border is an old English word to describe zone. It's not a line. The border is just the edge of the lip here. So that's vermilion border, this is vermilion border. The wet dry line is right where the mucus part of the lip meets the vermilion. The philtral columns come down here, and some people have them and some don't. As you get older, the philtral column splays a little bit, and you want to inject just on the medial side of the philtral columns to make them look more youthful. The white roll is this zone right where the vermilion meets the border, and it's just reflected light. It's a very youthful look. So that's what we're trying to get back as her white roll here, to have a nice youthful look to her lip. The Glagow-Klein points are right where the philtral column meets the vermilion tubercle. This is the vermilion tubercle. So that GK points are very important because it gives a nice, you'll see now they're flat. So when we get these properly reconstructed, it'll just lift that up a bit. It's very feminine. You can use needles, but we use a cannula for most of this, but we have to have a little entrance point. So this is a 27 gauge trocar, and you can measure the 27 millimeter here and see, because you want to go right up to this vermilion tubercle here where the GK point meets. So you can see in her case, it's going to be right here. You're doing the math a little bit. I'll try to go into a little pore so I stay away from the vessels. So a little spin on the trocar. And again, bending it to the shape of where you want to go with the bevel of the cannula up. Okay, and we'll just enter here. And it's just very, very slick. Get the sweet spot here. And I go right generally to where the philtral column meets the vermilion tubercle. And normally I would feel this because it's a two-handed procedure, but I want to have the camera see it here. So just subtle. And then we'll go above the lip a little bit where she's just sunk here a little bit. Just do a little sheeting of product just to make that smoother there. And you can see right here, we just need a little attention right there. So what I've done is, in the sweet spot of the sweet zone, it's not a spot, it's a zone, I've gone just subdermally here into the white roll and just subtly retrograde and antegrade both, lifted that up. So it just creates a little lift to her lip as well as redefine it. You just gently blend it. So that's 27 gauge trocar is fine for these 30 gauge 27 millimeter cannulas. Again, I'm bending that just a little bit to have the flow. And it's a two-handed procedure. And sometimes you'll have a little tiny vein here, you can see. So we're in subdermal, and you can see the tip of the cannula right there where the philtral column meets the vermilion tubercle here. So open them out just a little bit so you can see. So I'm injecting a small amount retrograde and antegrade, mostly retrograde here. Try to keep my fingers out of the way here. Then we'll go above the lip where she's got these little lip wrinkles and just fan this out and do a little tiny bit of sheeting of product, just little tiny bits. Okay? And then while we're on this side, we'll go sub-vermilion. So I'm just barely in the vermilion itself. You can see that little cannula right here. Try to tip it up a bit right there. So I'm in the sub-vermilion zone. Tiny bits of sheeting of product. The sheeting effect smooths out those reticulated lines of the lip. Okay, now we'll do the other side and then I'll blend that in there. He has this aging reticulated lines on the vermilion part of the lip here. And I'm going to be right sub-vermilion. You should be able to see that head of the cannula there. And we do just tiny bits of product right in the sub-vermilion zone here. Before we blend that, we want to inject right at this little corner that we didn't quite get. We'll just lift this a little tiny bit above the red of the lip. That side's perfect. Okay? Gel. Okay, the gel is really important to blend this. Open your mouth a little bit. Okay, the last part is to get the GK points here at the base of her philtral columns. So the base of the philtral columns, where it meets the vermilion tubercle, is critical for a feminine look here. So it's going to hurt just a little bit. We just lift those little tiny bits. Just a little more in this philtral column here. While her lip is kind of sitting here a little bit, we'll do these lines along her cheeks that patients seem to dislike. Open your mouth a little bit. And because we're in the sweet spots, these just blend in really, really nicely. So with Karen, the aim is improvement, and with her cheek, with the blueprint of the cheek, is trying to reestablish the feminine cheek, which is the apex is in line with 1 centimeter lateral to the orbital rim in a line drawn perpendicular down from the face, keep it in plane, and then a horizontal line from the top of the tragus to the alar crease. And we discovered just by looking at her and measurements, doing the math, that her apex was really pretty good already. But she was missing the submalar part of the cheek. And that's where we start, even in people who have no apex. So we lifted the submalar part of the cheek, a reflation technique. And then next, a little bit on her preauricular part of the cheek. It's not connected, it's just part of the same zone. Lifted that in the subcutaneous tissue and went over to the medial part of the submalar part of the cheek and lifted that right on top periosteum. And then same with the pre-jowl, or with the nasal jugal groove. It was just part of this cheek complex, lifted that right on top periosteum. So the last part was the apex, just a little bit on the apex. We give the cheek what it needs, and then what it wants is making sure the apex is right. The next step was to address her temporal fossa reflation. And the temporal fossa was giving her a peanut look, and you want it just a little bit concave, but not convex. So you don't want to correct it totally. So right on top periosteum, but essentially you're in muscle, and you lift the area that's deflated a little bit with the syringe and needle, and as it's lifted, then you inject antegrade, and that filling creates the lift, and that contour is nice, and just very, very subtly concave there. You just want it corrected. You don't want to have it change your persona because you've got a narrower face. If you made that a little bit convex at all, it would look masculine. And the next step was get the lower part of the temporal fossa where it meets the brow, and that was causing part of her brow ptosis here, where the brow was hanging down a little bit. And gently lifted that, and that lifted that tail of the brow. And then next we injected the head of the brow where it meets the radix, right vertical on top periosteum, and stay there while you're lifting and pushing antegrade so you don't interfere with any vessels. And then with the cannula, you can use different products, and that recontoured her brow more at the head of the brow and tapered as you go towards the tail. Next step was to do a little bit in the A-frame, which is this hollow area underneath. She doesn't really have a true A-frame. A-frame is usually in blepharoplasty patients where they've taken too much fat out and it creates a hollowing in an A pattern. But in her case, she was hollow a little bit underneath the brow in the supraorbital part of her rim. So in the superior orbital part, we did a cannula and with a 30 gauge cannula and filled this gently to reflate, contour, not so much reflation, but contouring of the brow. So we get this fourth dimension, which means we've done the head of the brow where it meets the radix, the brow popper, the above the brow where the brow and the temporal fusion line and the temporal fossa meet, and then into the supraorbital part of the brow here as well. So those four things to lift it. And then repeated that same procedure on the other side, trying to create harmony even though one side's a little different in all of us. And then keeping with the radix of the nose, hold the bridge of the nose and the radix area right on top periosteum to lift this whole structure that's slightly deflated. And then we understand that noses with time, the columella retracts a bit and the nose tips down. So with animation, if you watch people, you'll see this with the depressor septi muscle here, it tips down and it lifted this back up to the 95, 100 degrees rather than 80 degrees that it was. And the next step was to address the chin blueprint. So when you're doing chin reflation, it's not just doing the mentalis like doing a chin implant. It's addressing the lateral commissure, marionette zone, pregial sulcus, and the mentalis. So the key to success in all degrees of deflation and contour changes is to reflate, contour the pregial sulcus. Next step is above that, you're building a foundation, a strut work, a support tissue. And right in the subcutaneous tissue here, and then the lateral commissure combined with the marionette zone. You lift this up and make sure when you're doing the lateral commissure you get above the red of the lip as well so you can lift that corner. Then the last step is to do the mentalis proper. 3 zones is about right. Vertical, right on top periosteum. Touch it, lift a tiny bit with your syringe and needle. And as you inject antegrade, it creates the lift. And then contour this all into shape. The next thing we did was to understand that her lips are beautiful, but she just needs a little more youthful appearance to the upper lip. The upper lip was maturing ahead of the lower lip. So we didn't touch the lower lip. The lower lip is beautiful. So we did the white roll of the upper lip with a 30 gauge cannula with Fobella, blended it into shape, and then a little bit above the lip where these little lines are starting to create some sinking, more on the left side than the right side, because the left side is the driver's side and has a few more little wrinkles here. So we did that subdermally with the cannula as well from the same trocar. And then we went in the same trocar and did sub-vermilion sheeting to erase these aging lines, almost like injectable lipstick. Just filled that whole little zone. The last step was to do the Glogau-Klein points, which is where the philtral columns meet the volumen tubercle. And that's done with a 31 gauge needle, tiny amounts, retrograde with a 31 gauge needle. And we blended that all into place. So that was her project, and I'm all beat up.